Welcome, everyone, to this episode of the Journal of Clinical Anesthesia, the monthly podcast, where we highlight noteworthy articles from each issue. I'm Julian Ressler, Assistant Social Media Editor for the journal, and your host for today's interview. I would like to offer a really warm welcome to Dr. Christopher Wolla, the lead author of an article from our June issue titled Ultrasound Assessment of Preoperative Gastric Volume in Fasted Diabetic Surgical Patients, a prospective observational cohort study on the effects of GLP-1 agonists on gastric emptying. Thank you so much for taking the time to talk with me today. Let's start with a short introduction. Chris, could you tell us a bit about yourself and your role in this study?
Absolutely, yes. Thank you for having me. It's an honor to have this interview. But yes, I'm Chris Wolla. I'm an assistant professor of anesthesiology at the Medical University of South Carolina in Charleston, South Carolina. And I was the principal investigator on the study about the GLP-1 agonist and ultrasound assessment of their gastric volumes.
Very good. Thank you so much. So, could you briefly summarize your study? Specifically, could you explain the main objective of the study and what were your key findings?
Yes, absolutely. So, the main objectives we were looking for is there a difference in gastric volume um, between fasted patients that are on GLP-1 agonist medications versus those that are not on them? Specifically, our patient population was looking at diabetic patients coming in for elective surgeries that had followed standard ASA fasting protocols. We hypothesized that patients taking the GLP-1s would indeed have higher gastric volumes than their counterparts that were not on the GLP-1 medications. This ended up being a prospective observational cohort trial of 206 patients. We had 106 patients in the GLP-1 receptor agonist group. 98% of those patients were on weekly subcutaneous dosing. And then we had 100 in our control group. Our key findings were that in patients that were on GLP-1 agonists, they had a greater volume on average than those that were not on the GLP-1s. The median for patients on GLP-1 agonist was 0.61 mLs per kg of gastric volume versus 0.16 mLs per kg for the patients not on those medications. In terms of secondary endpoints, we found that there was a 11.3 times higher risk of a full stomach. We define that as a gastric ultrasound containing solids or greater than 1.5 mLs per kg of liquid. So the patients that had taken GLP-1s within the last month had an 11.3 times higher odds of having a full stomach. We further looked to see if there was a difference in the duration of them holding the medication. And we parsed that out into three groups. So we had patients that had taken it within 7 days, patients that had taken it between 7 and 14 days, and then those that had taken it greater than 14 days away from their surgery and their gastric ultrasound. So we found that there was large differences in between those that had taken it less than 7 days prior to their surgery. They had a median volume of around 1.3 mLs per kg, as compared to those at 7 to 14 days of 0.4, and greater than 14 days had gastric volumes on the median of 0.5 mLs per kg. This was all statistically significant from the control group, which had 0.3 mLs per kg. So those were the kind of main findings we had from our study.
Thank you so much. So, obviously, the 11 times higher risk for full stomachs, that's a pretty significant risk. You also mentioned the primary outcome of the gastric volume, where you had 0.61 mLs per kg versus 0.16 mLs per kg. Do you interpret, well, you obviously interpreted these findings as clinically significant as well. What is your reasoning there? Could you explain a little bit further what are clinically significant differences in gastric volume for you?
Yes, absolutely. So, I mean, I think our study kind of shows, like we've seen in multiple other prospective studies as well as case studies, that GLP-1 users are, most likely at a risk of having higher than normal gastric volumes despite appropriate ASA fasting. And specifically in our study, it was shown that, because the vast majority were on the weekly dose GLP-1s, and this has been a stated risk factor in many of the recent kind of recommendations and publications, they do have a high, significantly higher fasting gastric volumes, whether or not they held it or sorry, if they had not held it for at least 7 days. So I think a lot of the new recommendations, specifically the newest one from the British Journal of Anesthesia, it states that as a risk factor, the weekly dosed GLP-1s. So I think it just shows the importance that we look at each patient and kind of see if they have or do not have these risk factors, and that can kind of tell us how to proceed further.
Yeah, definitely. Um, and so, unfortunately, one participant in the GLP-1 group experienced an aspiration event. Um, this patient did have preoperative gastric volume. You stated it to be 0.5 mLs per kg of clear liquids. So, specifically for if you were clinically, is there a safe cutoff for gastric volume? Do you think, do you know of any evidence there?
Yeah. I think, from what I've seen, the most agreed upon value is of normal gastric secretions is about 1.5 mLs per kg. So that's kind of how what we used as our cutoff for a full stomach in our study. But there are some, publications that have lower cutoffs, such as 0.8 mLs per kg. In this specific patient, I think it's probably safer to say that this was a regurgitation under anesthesia. It's very hard to know if they actually had aspirated the contents. They did not have any sequelae of an aspiration if it did occur, because it was a non-particulate bilious fluid. And I think that can really happen with any amount of gastric volume. We're just trying to find the right number to kind of risk stratify. So are they at a high risk for regurgitation under anesthesia and aspiration, or are they at a low risk? So I think even seeing that patients below those cutoffs, while they're still at low risk, it's not no risk. But I think the most agreed upon and what we go off at our institution is the 1.5 mLs per kg, as a full stomach and therefore a high risk of regurgitation under anesthesia.
All right, thank you. And so, as you mentioned, there are guidelines on this topic. The one of the first guidelines from the ASA in 2023 recommended holding weekly dose GLP-1 agonists for at least 1 week prior to elective surgery. More recent publications, for example, the British Association of Anesthesists guidelines from this year recommend GLP-1 agonists may be continued perioperatively, emphasizing an individual patient risk-based process. How would your data impact these guidelines?
Yeah, I think the kind of the trend is going more towards having the patients continue these perioperatively, and I think our research kind of shows that the weekly dosed GLP-1s are indeed a risk factor. There's several different risk factors that they kind of denote in multiple of the recommendations, whether that's a weekly dose GLP-1 or if the patient is in a escalation phase of their dosing protocol, if they're on high dose versus low dose, as well as the presence of severe GI symptoms. So I think it's just very important to, with these newest guidelines, to kind of, or recommendations, that it is very important to do it on an individual risk-based process. But I think, with all of these kind of risk factors, all of it has been, because of the limited data, it's been hard to say, is this a true risk factor or is it not? I think kind of uh, our research does show that these weekly dose GLPs, especially if they're taken within 7 days of surgery, is a definite risk factor for higher gastric volumes. Personally, in my practice, I perform gastric ultrasounds on any patient that has not held their GLP-1 for at least 7 days if it's weekly dosed, and then I can kind of use that information to further manage the patient, whether that is, I wanted to do a peripheral nerve block with sedation. I may not want to do that anymore. May want to protect the airway and do a general anesthetic with an RSI. Or if I was going to use an LMA, then may want to use an ET tube instead. And that kind of just depends on several different patient factors, urgency of the case, and other risk factors for regurgitation and their comorbidities. But I think overall, with all of these different guidelines coming out, definitely more research is needed to investigate different risk mitigation strategies in patients that are going to continue these GLP-1 medications perioperatively. And a lot of the ones that have come out looking at 24-hour clear liquid diet instead of standard ASA fasting protocols would be good to look at. So I think in the future with these guidelines, we kind of need to figure out, are the recommendations that these risk mitigation strategies, are those going to be helpful in these patients? So I think we'll find out more here in the near future.
Very good. And aside from the interesting data on gastric contents in these patients, also, I mean, your study is a great example that incorporating gastric ultrasound into maybe even clinical practice could be also a great idea that we should all keep in mind. This is already the end of our interview. Chris, thank you so much for coming and talking to me.
All right. Thank you for having me.